Hello and welcome to my channel. This is a course called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before the finals. In this video, I'll be starting on part 1 of the Vascular Series. Do check out the links below in the description if you want the slides from this video on my website and also flashcards, which I've uploaded on Pinterest. Let's begin. In this video, we will be covering peripheral arterial disease, acute limb ischemia, deep vein thrombosis, varicose veins, and chronic venous insufficiency. Peripheral arterial disease and acute limb ischemia, whereby the pathology lies in the arterial system of the legs, deep vein thrombosis, varicose veins, and chronic venous insufficiency, whereby the pathology lies in the venous system of the legs. The first one, peripheral arterial disease. It is the narrowing of arteries supplying the limbs and periphery, causing a reduction in blood supply to these areas. It's usually affecting the lower limbs. So some clinical features to take note: intermittent claudication. So intermittent claudication involves symptoms of ischemia in the limb, which usually happens during exertion like walking after a certain distance, but it is relieved with rest. So when you take their history, it's important to ask how long have they walked or how long do they walk before the pain comes, and does it persist during rest or does it go away? Next is critical limb ischemia. So there are 6 P's to take note of, and the 6 P's are pale, pulseless, painful, paralysis, parastatic, and perishingly cold. Not all 6 P's will be present, but it's good when you're taking a history to ask about all these things or to take note. So in the case of parastatic, there's usually this numb and tingling feeling. So in critical limb ischemia is actually the end stage of peripheral arterial disease, whereby the person has been experiencing it for some time, and when there is inadequate or not enough blood supply to the limb to allow it to function normally, even at rest. So even at rest, they will be having pain, or sometimes when you were to check and notice the limb, the 6 P's are present. They might even have non-healing ulcers or gangrene, hence non-healing ulcers or gangrene. It is typically a burning pain, which is worse at night when the leg is raised, because gravity is no longer able to help pull the blood back to the foot. Others to take note would be acute limb-threatening ischemia. So acute limb-threatening ischemia, the word acute means sudden onset, rapid onset, very fast. It happened over a short period of time. So it is the rapid onset of ischemia in a limb, which is usually due to a thrombus, which is a blood clot, blocking the arterial supply of a distal limb. Others to take note would be weak or absent pulses or skin and hair changes. It is strongly linked to smoking, and there are other comorbidities that can help contribute to this peripheral arterial disease. So the person may be having long-standing hypertension or diabetes mellitus or uncontrolled diabetes mellitus, obesity, or even high cholesterol. So on physical examination, after you've taken the history and also take note of these clinical features or even ask them, is the inspection. So you move on to physical examination. On inspection, you will notice some skin pallor, sometimes even cyanosis, dependent rubor. So some parts are red, some parts are not. There may even be muscle wasting because there's inadequate blood supply, right? So there might be muscle wasting due to lack of use of that particular muscle or lack of blood supply to that area. Hair loss, ulcers, poor wound healing, or gangrene. Of course, that's dependent. Some may not have all this presentation, but if they are having critical limb ischemia or long-standing peripheral arterial disease, they may have skin pallor or muscle wasting and hair loss. Sometimes they may even have ulcers or poor wound healing. Eventually, it may progress to gangrene. So usually when they come in, it's usually towards gangrene or sometimes even in the gangrenous stage. So on examination, there would be reduced skin temperature because, with skin pallor and cyanosis, meaning there's inadequate blood supply to that area. There may even be reduced sensation, and if you were to check the capillary refill time, it is prolonged more than 2 seconds. So the investigation that you would do for this, the first line would be a Doppler ultrasound, and you can also check the ABPI. ABPI stands for Ankle Brachial Pressure Index. The formula for that would be you take the systolic BP of the ankle, divide it by the systolic BP of the arm. You will get a value. And here are the range for ABPI. 0.9 to 1.3 is normal. 0.6 to 0.9 would be mild PAD, peripheral arterial disease. 0.3 to 0.6 would be moderate to severe. And less than 0.3 could indicate severe disease to critical ischemia. So this is just a little bit about the peripheral arterial disease symptoms and the area of occlusion. It's good to take note of this because sometimes they might ask you in MCQs or even during bedside teaching after you've clerked the patient and presented your case and findings to the specialist or the lecturer. It's good. Sometimes they might even ask so which area or which artery do you think is probably occluded, and well, here you go. Alright, so the treatment for this would be nephidrofuryl oxalate, which is a vasodilator, and clopidogrel. Most of the time they would offer revascularization surgery, especially in critical limb ischemia, which is long-standing. There are a few, so there's endovascular angioplasty and stenting, an endarterectomy, and a bypass surgery, depending on the degree of the occlusion. Next is acute limb ischemia. It is a surgical emergency that requires urgent revascularization, which is through angioplasty or open surgery, in 4 to 8 hours to save a limb. So earlier we talked a little bit about peripheral arterial disease, and under peripheral arterial disease, there would be critical limb ischemia, which is long-standing, and eventually the limb turns paler and there's loss of hair, loss of sensation, and eventually gangrene. But in the case of acute limb ischemia, it's sudden onset, it happens suddenly, and it's due to a blood clot that blocked the arteries. Now, it's a surgical emergency because blood is not able to flow to the distal limbs. It's not able to flow to that particular limb, and if it's not saved, if the clot is not removed, then there's no reperfusion, there's no blood flow, and eventually the limb dies off. Should you take note would be the 6 P's as well, as I mentioned earlier: pale, pulseless, painful, paralysis, parastatic, and perishingly cold. Causes, most common cause would be embolism and thrombosis. And in the case where there is presence of acute limb ischemia as well as irregular pulse, it's likely due to arterial fibrillation. Sometimes trauma and compartment syndrome can contribute to acute limb ischemia. Any patient with previous history of peripheral arterial disease with deterioration of symptoms, meaning the presence of the 6 P's, as I mentioned over here, should point towards acute or critical limb ischemia. Hence, when you take the patient's history, it's important to know, has this happened before? Have they been admitted before? Actually, do they have any long-standing PAD? And apart from that, it's important to take note of their comorbidities because this is very common, or it happens a lot in patients who are long-standing diabetes mellitus, and usually it's uncontrolled. So the treatment would be similar: endovascular thrombolysis, endovascular thrombectomy, surgical thrombectomy, endarterectomy, bypass surgery, or in the case where you are not able to save the limb, then it is amputation. So endovascular thrombolysis involves inserting a catheter through the arterial system to apply thrombolysis directly into the clot. Endovascular thrombectomy involves inserting a catheter through the arterial system and removing the thrombus by aspiration or mechanical devices, so it's less invasive. A more invasive one would be the surgical thrombectomy, which involves actually cutting open the vessel and removing the thrombus itself. Third is deep vein thrombosis. It is a form of venous thromboembolism where blood clots, thrombi, develops in the venous circulation. So earlier, when we talked about peripheral arterial disease and acute limb ischemia, we were talking about the clots that developed in the arterial circulation. So venous thromboembolism, does this sound familiar? In one of my video in the cardiology series, I've talked about pulmonary embolism. Venous thromboembolism comprises of pulmonary embolism and deep vein thrombosis. In pulmonary embolism, the blood clot forms in the lungs, or the blood clot from the legs gets stuck in the lungs, and patients will usually have shortness of breath. Some clinical features to take note: cough or leg swelling, dilated superficial veins, tenderness to the cough. So usually when the patient is lying down, they just need to raise their legs a bit with the feet flat on the bed and just give the cough a squeeze, and they would usually tell you it's pain, or they would just scream. So there's tenderness over the cough, and there may be edema, and also color changes to the leg. The first line investigation would be the 2-level DVT Wells test, or the DVT Wells score. The diagnostic test would be a Doppler ultrasound. So some risk factors to take note, especially when you're clerking or taking the history of the patient. Have they been immobile for long periods of time, usually after a plane ride, or are they just generally not active? Because this can cause venous stasis, which means that the blood tends to pool at a certain area for a long time. Have they had any recent surgery? Because this could cause endothelial injury, causing the formation of thrombus. Have they had any long-haul travel, as I mentioned earlier, flights, especially long flights where they did not stand up to walk or go to the toilet, just totally sit down. Pregnancy, because they tend to be in hypercoagulable state. Are they on any hormone therapy with estrogen, because it increases the hypercoagulability as well? Any malignancy? Are they having any form of cancer, or are they on treatment for their cancer? Polycythemia, SLEs, and thrombophilia. So treatment would be DOACs, first-line treatment, apixaban, rivaroxaban for 3 to 6 months. And in cases where anticoagulation therapy is contraindicated, such as in recent hemorrhagic stroke, usually the management would be using a surgical thromboembolectomy, whereby you cut open the vessel and you remove the thrombus. So this is the 2-level DVT Wells test. Here are a few points to take note, and each of them contribute a score of 1, except the last one, which is an alternative diagnosis, least likely of a DVT. This is the first line that you would do. A score of 2 or more points to a DVT being likely, and a score of less than 2 points to DVT being unlikely. So like active cancer, any paralysis or paresis, or recent plaster immobilization, recently bedridden for 3 days or more, or major surgery within the last 12 weeks, localized tenderness, entire leg swollen, cuff swelling, at least 3 cm larger than the asymptomatic site, pitting edema, collateral superficial veins, previously documented DVT. And this is how you go about the investigation and the management. As I mentioned earlier, the first line investigation would be the DVT Wells score. So you calculate that, which is to assess the possibility of a DVT. Note the word here, possibility. Then you proceed with a proximal leg ultrasound, which is the definitive test. If the score is less likely of a DVT, meaning it's probably not a DVT, which is less than 2, then you proceed with a D-dimers test. A D-dimers test is not definitive, but it will be positive in the case of a DVT. However, it can also be positive in other conditions, hence it's not suitable to be diagnostic of a DVT. If the D-dimer is positive, then you can proceed with a proximal leg ultrasound. Hence, first you calculate the score. Is it 2 or more, or less than 2? So 2 or more is suggestive of DVT. Hence, you proceed with a proximal leg ultrasound. If the DVT Wells score is less than 2, which is not suggestive of a DVT, but you think the person might actually be having a DVT, then you proceed with a D-dimers test, and if it is positive, then you proceed with a proximal leg ultrasound. Moving on is varicose veins. So varicose veins are distended superficial veins measuring more than 3 millimeter in diameter, usually affecting the legs. So a little bit about veins. Veins contains valves that allows blood to only flow in one direction, meaning there shouldn't be any backflow, which is towards the heart. And in the legs, as the muscle contracts, they squeeze the blood. They aid in moving the blood back to the heart, upwards against gravity. Basically, valves here, they prevent the gravity from pulling the blood back into the feet. However, when the valves become incompetent, like over here, they're deformed, the blood is drawn downwards by gravity and pulls in the veins and feet. Alright, so now the veins consist of two types, which are superficial and deep veins. And these two, superficial and deep veins, they are connected by tiny vessels called the perforating veins or the perforators. These perforators allows blood to flow from the superficial into the deep veins. And now when the valves are incompetent in these perforators, the blood flows from the deep veins back into the superficial veins and overloads them. So you see there's a backflow and it will be overloaded. This causes dilatation. As you can see here, it's dilated, and engorgement of the superficial veins, forming the varicose veins, as you can see here. Surely we know a few people who have varicose veins, and it's very obvious to see. It's very tortuous, it's very dilated, and it's usually in the legs or the feet. So clinical features: dilated and tortuous veins in the lower limb, discomfort or itching or ulceration, usually on the medial side, heaviness of the leg, and there's chronic venous insufficiency presentation. I will talk more about this chronic venous insufficiency presentation in the following slide. However, take note of this presentation, which would be brown discoloration to the lower legs, venous eczema, and lipodermatosclerosis. So some risk factors that contribute to the varicose veins formation would be job involving prolonged standing, pregnancy, obesity, or just commonly within old age, more than 65 years old. So this is what I wanted to talk about, which is the chronic venous insufficiency presentation. So when the blood pools in the distal veins, when it actually pools, it causes an increase in pressure. So this increase in pressure will cause the veins to leak out small amounts of blood into the nearby tissue. Now some bloods are being leaked out, right? What happens next is the hemoglobin from those bloods that has been leaked out breaks down into hemosiderin, and this hemosiderin will be deposited around the shins in the legs, and this will give a brown discoloration to the lower legs. But apart from that, this pooling of blood also causes inflammation. So inflammation will then cause the skin to become dry and inflamed, and this will be referred to as venous eczema. The skin and soft tissues will then become fibrotic and tight, causing the lower legs to become narrow and hard, referred to as lipodermatosclerosis, an inverted champagne bottle of the legs. So when you conduct a physical examination on the patient, so it's important, apart from asking the history and noting the presence of varicose veins, it's important to take note: are there any brown discoloration? How about venous eczema, is it present? And also the presence of lipodermatosclerosis. The investigations to be done: usually a duplex ultrasound straight away, but you can also perform a tap test and a cough test. Treatment: the preferred would be minimal invasive procedures such as endothermal ablation, sclerotherapy, or even surgical removal of the vein. But here are some simple treatment measures: weight loss if appropriate, because sometimes person may be obese and this contributes to the formation of varicose veins, but it does not actually help much once the varicose veins have been formed, but it will be good for the patient as well, because it will alleviate the weight on the affected limb. staying physically active, keeping the leg elevated when possible to help drainage, because due to the valve being incompetent, there is backflow of blood. And why you should stay physically active, as I mentioned earlier, the muscles help in pushing the blood back to the heart. So just being inactive won't actually help much. Now, it's better to be physically active, and it's better for the overall health as well. And also compression stockings to basically just press on the area and guide the flow of blood back to the heart. Moving on is chronic venous insufficiency. This occurs when blood does not efficiently drain from the legs back to the heart, usually as a result of damage to the valves inside the veins, which is varicose veins, as I was talking about earlier. So this damage may occur with age, immobility, obesity, prolonged standing, or after a deep vein thrombosis, and is often associated with varicose veins. So when you see a patient with varicose veins, think of chronic venous insufficiency as well. Remember the presentation. It's important to keep these two in mind. So the most common area affected would be the gaiter area. So that is the area between the top of the foot and the bottom of the calf muscle. Clinical feature, as I mentioned earlier, hemosiderin staining, which is a red or brown discoloration caused by hemoglobin leaking into the skin, venous eczema or varicose eczema, which are dry, itchy, scaly, red cracked skin caused by chronic inflammatory response in the skin, lipodermatosclerosis, where the skin tissue becomes fibrotic and tight, which causes the lower legs to become narrow and hard, giving it an inverted champagne bottle appearance, atrophied blanche, which are patches of smooth porcelain white scar tissue in the skin, often surrounded by hyperpigmentation. So you'll see dots, you'll see white spots. And the complications that could arise from chronic venous insufficiency would be cellulitis, poor healing after injury, and skin ulcers, and also pain. The management of this would be keeping the skin healthy, improve venous drainage to the legs, and managing complications. So sometimes the patient may have infection to that area, and if there is, antibiotics for bacterial infection, analgesia for the pain, and wound care for ulceration. If you've reached this part of the video, thank you so much for watching. Please hit the subscribe button and press the notification bell so you don't miss out on any new videos. I post videos weekly. See you in the next one.